Hello everyone, my name is Rebecca Divac and I am a primary care nurse practitioner student at UT Arlington. I selected the topic Encopresis to talk about because I've actually experienced this in my youngest son and I have some funny backstories to share with you along the way. So we're talking about Encopresis, which actually has become an outdated term, and they now are preferring to label it as functional fecal incontinence. So now that it has been officially named functional fecal incontinence, it's been defined as repetitive, voluntary, or involuntary passage of stool into the underwear or inappropriate places in a child who's old enough to have mastered toileting skills, which is typically age 4 and up, and does not have another organic cause for incontinence, such as neuromuscular dysfunction or Hirschsprung's disease. So if a kiddo has encopresis or functional incontinence, they could have two types. Functional incontinence without constipation. So these kiddos are not constipated, but they have bowel movements into their underwear or in inappropriate places, such as hiding in the pantry. Remember, this is different from the process of potty training. They've already potty trained. They learned how to use the bathroom appropriately. They're old enough to do so. But they've taken a step backwards and they're demonstrating all these accidents per se. And I say hiding in the pantry because I have a nephew that's doing that right now. So number 2 is when we have functional incontinence with constipation. And these kiddos develop large volumes of stool that are difficult to pass, and they'll have leakage of liquid stool around the mass, and they can also accidentally leak pebbles of stool. So this is like a classic form of encopresis that's caused by constipation. And because of that large mass of stool, they can't even feel the dripping of the liquid stool around it. It's completely involuntary. There are differential diagnoses. Just because the kiddo is having involuntary soiling in their clothes or they are having difficulty choosing the right time or the right place to have a bowel movement, that doesn't mean that they automatically are diagnosed with functional incontinence. Functional means that there's not some other disease behind it. For example, Hirschsprung disease causes severe constipation, so you could have that massive stool and then the subsequent leakage around it. Cystic fibrosis, they have thick mucus and they have dry, hard stool sometimes. They have problems with their pancreatic enzymes. These things can cause constipation and subsequent leakage. Hypothyroidism, that really slows down the digestive system. Cerebral palsy, their GI tract muscles might not work very well. Spina bifida, you have neuro damage. And then sadly, sexual abuse can be a cause of fecal incontinence. If they have, I choke on just thinking about that. If they have been the victim of sexual abuse, such as anal sex, then they could have damage that's causing them to have subsequent fecal incontinence. So if a child has a medical history or symptoms that point to a disorder such as these, further evaluation must be performed, and the diagnosis is not functional fecal incontinence. It's a symptom of that underlying disease. So they either need to be treated, further testing performed, or referred. So there is specific Rome 4 criteria for diagnosis of functional constipation in children. That means they don't have some other underlying disorder causing the constipation. With this criteria, you need to see that they have 2 or less bowel movements into the toilet a week. Notice it says into the toilet. they have at least one episode a week of fecal incontinence. They have a history of purposeful posturing to retain stool. So they are, feeling uncomfortable. You see it in their body language. You see it in their face. They're bending over very carefully, and they are actively retaining the stool. They have large or hard to pass stool. They have large diameter stools. So with my son, for example, we used to be shocked by the diameter of stool in the toilet and thought, oh my gosh, how can a little kid have poop this big? I didn't know at the time that this was the result of his functional incontinence. And then remember once again that no other medical condition potentially causes these symptoms. So this is a quote from my son. "Don't be mad," he said. There was a time that he was squatting in the living room and just playing with a toy, and some pebbles of poop dropped on the floor. And he said, "Don't be mad." And he really didn't do it, of course, on purpose. The entire family was there. It was very embarrassing for him. He was scared that we would be angry. And then going to school, kids can be ridiculed if they have accidental stooling into their pants. They are not doing it on purpose. This is a terrible experience for them, and we have to remember that and not make it even worse by shouting at them and punishing them for something that they're suffering with. So how do we manage? How do we manage functional incontinence with constipation? First of all, we have to assure parents that the child's not soiling intentionally, that they may feel embarrassment, helplessness, and fear. Oftentimes it starts because of a single event and may go into a bad cycle. So let's say one time the child was a little dehydrated, or had been traveling and they didn't want to use the potty at a public place, things like that, and they had one bout of constipation. That one bout of constipation can actually cause that cycle to start of retaining the stool. It becomes so large, so hard, then it hurt very, very much to pass it. Then when a young child, that alone can be enough for them to start to be afraid to go poop in the potty. So prevention is the primary treatment. For treatment, after the fact, we already have a problem with incontinence and constipation. Polyethylene glycol solution, better known as Miralax, is the first-line pharmacological treatment recommended by the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. There's other options. Polyethylene glycol dose is based upon weight. It has to be mixed with fluids. If the parents are not willing to use Miralax or the child's not willing to drink it, lactulose is a second choice, and it can be used in the event that Miralax isn't available or wanted. Other options that families might want to try for maintenance or as a second line of treatment include milk of magnesia, senna, mineral oil, or biscuitol. Enemas are not recommended as an add-on maintenance to Miralax therapy. Furthermore, enemas can be kind of traumatic for the child. They're not going to think that's pleasant. So polyethylene glycol treatment concerns. Well, nowadays a lot of parents look at things on Facebook and who knows what on their Google searches. And so they may come to you with concerns, and you can assure them that it is the first-line therapy per national guidelines, in fact, international guidelines. Like many medications, it's not FDA approved for treatment of constipation in children, so the label only provides direction for adults, and it's directed only for 2 weeks. But that just means that the medication didn't go through FDA approval studies. It doesn't mean that the medication's not safe. There's been many long-term studies that show that polyethylene glycol is safe and effective for the treatment of constipation in children. What about functional incontinence without constipation? Well, that means it's not due to constipation or retention. They don't have leaking of liquid stool around a mass. They're just leaking stool. It could be due to developmental delay. It could be due to behavioral problems or fear related. Some kiddos become really scared of flushing the toilet, so you should never flush the toilet while they're sitting on it. Some may just be unwilling to stop their play activities. So you see this encopresis or functional incontinence with or without constipation more in boys. Because boys, they just want to run up to the potty, go pee-pee really quick and leave. And to go poop in the potty, you got to slow down a minute, take a bit of a time out, and sometimes they're so busy with their video games or things like that that they get caught up, and that can add to the cycle of constipation too. They may not like to use the toilet at school. And once again with boys, not accustomed to sitting down on the potty at school or in public, that can lead to functional incontinence without being constipated. They just might have that urge, but they don't feel comfortable with using a strange toilet, and then they end up leaking into their clothing. And then we also, once again, have to think about, is this a symptom of abuse? For example, with anal sex, like we mentioned before. If they are having incontinence, they're not constipated or having any symptoms of constipation, we have to look for possible signs of abuse. So how do we manage if they have incontinence but they're not constipated? What do we do for that? Well, with this, we focus on behavioral interventions rather than a pharmacological approach. And in this case, laxatives and stool softeners are not recommended. We provide education regarding toileting routines, and we recommend that they designate a relaxed daily time for BMs. And we provide education regarding proper fiber, fluid intake, and physical activity. Finally, we have to promote a positive, compassionate attitude, educate the family that treatment might take months, even years of ongoing treatment, and continue to work together through follow-up to prevent recurrence of symptoms. And these are all my references. Thanks for listening.